So welcome to all of you to attend panel discussion. Do you have any comments or question to this presentation? I'd like to have Dr. Huang, please. Would you like to go first? Dr. Huang, please.
Yeah, thank you, Professor Zhou. Thank you, Professor Wakelee. I think this section we talk about the early and locally advanced non-small cell lung cancer, especially in the ctDNAs in predict the outcome of the benefit in the immunochemotherapy in the new adjuvant. So one question I asked Wakelee, lastly, is more interesting study about association of radiomedical factors with or without ctDNA detection with the treatment outcome analysis from engines. In his conclusion, we see he think the how to say in the model training use radiomac factors with and without C3D1 ctDNA stage in the development map predict PCR and outperform the models training use the baseline clinical factors. So in his the conclusion, maybe the clinical factors is more important to early response biomarkers than the ctDNA. How do you think these results?
Thank you. I think that it's a very intriguing analysis. I think from a biological standpoint, as we're trying to understand the disease. Personally, I still believe that if we can get the ctDNA analyses to be sensitive enough, that will be more informative. I'm biased, right, because I work at Stanford with Max Dean and Ashley Zadeh and others who are sort of at the cutting edge with ctDNA and now ctRNA technologies. And from that biological standpoint, if we can have a tool that allows us to see whether the cancer is really there or not, that's the ultimate way to sort of guide our treatment. When we think about early stage cancer for a patient who has had surgery, we know that many of them are cured because before we had immune therapy or chemo, patients were cured. And so we don't want to be over-treating those patients. So if we can limit just to the patients who need more treatment and then have a way to track whether that treatment is actually making a difference because it changes what we see in the biomarker, the liquid biopsy, that would be the ultimate tool. And so I have a hope that we would get there. When we look at the clinical factors and other factors, they can be sort of rough guides, right? But it's almost like when we try to decide if someone has an EGFR mutation in their tumor or not, to determine whether they're going to respond, we can look at them and certain factors and think, oh, they likely do. But that's what we did 20 years ago, right? Now we always do the testing because we know that we can be fooled by factors other than the science and the really precise testing. That's how I sort of think about it. But before we know how to do the precise testing, we can use other factors to help us guess better.
Thank you. So I think is the MRD assessment could be identify a subgroup of the poor progress, but his low positive rate is not it's not a good tool to predict outcomes. Thank you.
Yes, I think at this point it's not sensitive enough. It can tell us when someone's going to do poorly, but it can't tell us that we should be comfortable not treating further, even if it's negative.